Good evening, everyone. A very warm welcome to all the delegates, doctors, pharmacists, and participants present here at SYCCON S6, the 6th International Conference of RX Doctors, Day 18. This conference is a platform where medicine, pharmacy, and allied health sciences come together to share knowledge, inspire innovation, and build better healthcare for tomorrow. Before proceeding further, let's go through today's agenda. We are honored to have two distinguished speakers with us today. Dr. Jerry Ashwin, MBBS, MS in Otorhinolaryngology, Medical Director and Consultant ENT, Head and Neck Surgeon at Clinical Care Hospital, Anna Nagar, Chennai, and Dr. V. Anand Deepak, PharmD, PGDCR, Clinical Trial Manager, SMO, Chennai, patient advocate for clinical research and influencer. Gives me immense pleasure to introduce Dr. Jerry Ashwin. He is the medical director and consultant ENT, head and neck surgeon at Clinical Care Hospital, Chennai. He also worked as medical officer at St. Thomas Hospital and is a visiting consultant at Clinical Care Hospital, Prasanth Hospital, Beewell Hospital, VS Hospital, and Chakra Hospital. He is well versed in minimally invasive ENT surgeries with special expertise in rhinology, phonosurgery, and revision FESS, along with excellent clinical judgment and communication skills. With his strong expertise, he has presented and published widely in national forums. Today, he will share his insights on a fascinating emerging topic, which is Botox in ENT New Frontiers in Functional Use. Let's warmly welcome our first speaker to the session, Dr. Jerry Ashwin. The stage is yours.
Good evening, everyone. This is Dr. Jerry Ashwin, and thank you for SYCCON S6 for making me as a part of this forum. So today's topic is a little not a weird topic, but it's a very technical topic for us to know what is Botox. So are you able to see my slides actually?
Yes, sir.
Yeah. So yeah, good evening. This is a vague topic, but we should all know that there's something called Botox in the world, which gives us a lot of information regarding uh, treatments and side effects of the use of the same Botox uh, drug. I can't say it is a drug; it's just a part of a microorganism. So coming to the objectives, first I'll just talk about the basics of the Botox. So the mechanism of action of Botox and the complications of Botox. So coming to the introduction, it's just a basic go through the introduction. So Justinus Kerner was the first who actually found this disease called botulism, which was first in the US. It was a disorder called sausage poisoning. So following that, it was named as Clostridium botulinum, which is the bacterium from which the Botox was originally taken from. And there are multiple other people who have treated human diseases using this botulinum toxin, but the most common treatment was in ophthalmology, which is called as strabismus, which is called squint eyes, which is involuntary movements of the both the eyes due to a gaze induced nystagmus. And the first neurotoxin was first purified and precipitated by Sommer. So just the basic introduction in Botox. So coming to what is Botox, which is called as botulinum toxin, it's actually a neurotoxin, which is it acts on the nerves. So there's nothing else. So if nerves are affected, muscles will be affected. So it's actually from a bacterium called Clostridium botulinum, which is a gram-positive anaerobic bacterium. So it is the most common bacteria causing botulism, which is called as sausage poisoning, which I told you, which is paralysis of multiple cranial nerves, muscles, and everything. So there are many types of botulinum toxin, and each has its own distinguished action. So the mechanism of action is it directly binds on the cholinergic nerve terminals, which is directly stimulating the acetylcholine. So the main action of botulinum is to decrease the release of acetylcholine, which is a neurotransmitter from the muscles. So it is a neuromuscular blocking agent. So acetylcholine blocking agent. So during this normal acetylcholine production, there will be muscle reinnervation, sprouting of axons, which gives the terminal branches to the muscles, formation of new transmitter junctions, and ultimately regeneration of another neuromuscular junction. So this is the process of a normal neurotransmitter mechanism. So the main uses of botulinum toxin is mostly in the face, forehead muscles, strabismus at size, and other gait movements, which is very much not very invasive in this practice, but mostly Botox is used in the face. So there are many types of botulinum toxin. It has A, B, C, D, E, F, G. So basically, A is altered exocrine gland function, which includes salivary gland functions, minor salivary gland functions. Mainly, it's used in voice disorders like spasmodic dysphonia, facial palsy, yes, in terminal, levels. Facial scars very much used for cosmetic reasons. Dysphagia also is very rare nowadays, and tinnitus also is very rare. Tinnitus means ringing sensation in the ear, and G is very rarely other neuromuscular conditions, so it is very rare. So coming to the altered exocrine gland function, so as I told you, it blocks the acetylcholine release at the cholinergic neurosecretory junctions, resulting in the reduced glandular secretion. Once the axon's terminals are blocked, the neuromuscular junction will be blocked until the action of the dose. So basically, it doesn't transmit the paralysis. So it inhibits the spasmodic or muscle paralysis. So first, let's go to the Frey syndrome, which is gustatory sweating, which means that whenever you eat, you will sweat more. So basically, it's the autonomic nervous system problem, which the auricular temporal nerve is not supplying correctly to the branch of the parotid. So when you eat, the auricular temporal nerve dysfunction causes the sweating of the gland. That results in sweating of the face. So in this, botulinum A is actually the first non-invasive therapy for Frey syndrome. So usually it's given intradermally as 7.5 units per 4 centimeters. So usually, parotids are not more than 4 or 5 centimeters. So that's more a proper dose for the same. So reports have said that long-lasting but not a very big curative life, but supportive treatment and recurrent injections will cause good improvements. And 85% in a study has showed that there is no recurrence in a period of 11 months. So each year you can repeat the dose. So coming to sialorrhea, which is called as excessive salivation. So there is no reason for excessive salivation. Sometimes the gland, the exocrine gland secretion from the parotid is idiopathic for excessive drooling. Sometimes a block in the duct, a parotid duct or a Stenson's duct can cause sialorrhea. So in this treatment, we have other drugs called glycopyrrolate to reduce the salivary, gland excretion. But this is also one of the treatment, but the dose is around 46 units. It is actually recognized as a effective treatment, but the effect is only a temporary. Typically results from only 2 months to almost 6 to 7 months. So facial hyperhidrosis, which is called excessive sweating. So usually this is actually a trial study, but it has been working for a few people who are having excessive facial hyperhidrosis. The mean dose is 86 units. You can remember as sialorrhea is 46 units, and this is 86 units. You can just inject on the affected sites. Sometimes, the sweat test, which is called that minus iodine starch test, can be used to find the places of sweating. And inability to frown the forehead is also one of the reasons for facial hyperhidrosis, and this also results only for lasting for almost 5 months. And the frowning also can be one of the side. After putting the injection also, there'll be mild weakness of frowning also, which is least side effect in 1 or 2 patients. And a follow-up of these patients have been done, and facial hyperhidrosis has been a good relapse from the botulinum toxin A. And coming to voice disorders, coming to which is called spasmodic dysphonia. So this is called as dysphonia because there'll be breaks in the voice where you'll be not be able to complete the sentence fully, and it's more of a laryngeal muscle, that is the nerve muscle problem. So in this types are the most common is adductor, the next is abductor, and next is mixed. Mixed is very rare. So coming to adductor spasmodic dysphonia, this is actually an OPD basis procedure. So in this, the thyroarytenoid muscle, which is the one of the major muscles in thyroid, which is connected to the arytenoid, is one of the structures in the vocal cord, has been mucosally under local, probably on the local, been injected with botulinum toxin. And there are other ways of transfers of dose during the arytenoid muscle approach, which is through the cricothyroid membrane, which is a transcutaneous technique. So basically, this is how we do thyroarytenoid muscle membrane injections. So usually we do sterilize and we find the cricoid cartilage, and needle is actually 15 degrees cranially and 30 degrees laterally, is advanced into the body of the thyroid muscle. There'll be a push in the muscle and then it'll go freely, which means that you're inside the muscle. And usually local is not required unless patient is not very cooperative. So we use this EMG monitoring to see whether you're correctly in the muscle or you've been piercing in the nerve. So this is just a monitoring equipment to see whether the burst activity, when you go close to the nerve, this monitor will flick some nerve, some spikes in the uh, so-called monitor. So which means that you are not in the correct place. So usually we use around low dose botulinum toxin, 3 to 4, 10 units. Sometimes both the sites or equally in unilateral sites. Nowadays, people receive only a few doses because of the toxicity and because it directly grows into the vocal cord. And recurrent doses has to be titrated in order to see the patient's response. So dosing is usually every 6 months. This can be even required even 6 weeks. First, initially after the injection is done, the voice is little weak and breathy, and during this time you will have an aspiration of fluid. So maybe Riles tube may be required during these injections for further feeds. And after a week or so, the voice will reach in a stable state. And after 2 to 3 weeks after the injection, maximal state. So the study what they have given here is there are multiple studies in Russia, China, and Japan. Higher the dose, the longer the duration of action. But the more the dose, the more quality of life is compromised, like more breathy voice and more aspiration of fluids. So dose has to be calculated on every time and every intervals of treatment. So coming to adductor spasmodic dysphonia. So that is the thyroarytenoid problem, which is the adductor. Now this is the posterior cricoarytenoid problem, which is the only adductor muscle in the larynx. So this is also done transcutaneously by just going through the cricoid, and where the posterior ring can be easily pierced. So EMG guidance is usually needed for this because it's a posterior muscle, so it's more prone for damage during vocal cord injections. So sometimes people may require GA for injections, but the point is when you give GA, your larynx falls back. So this is performed during GA. We have to lift the larynx and we have to go through the quieting, which is a little more tentative uh, surgery for little difficult surgery for seeing the anatomy. And both the muscles, if you give, there is actually one paper where it has resulted in failure. So you have to at least give one muscle and see for the abductor function of the other, and then go for the next dose. So in this thing, a larger dose is always required to achieve the the results, rather than in abductor where we do with small doses. So coming to stuttering, which is one of the most no reason for stuttering. Most of the common reasons are mostly because of cerebrovascular accidents. And in this is actually a trial study, almost a pilot study. So only one there was nowadays it's not being used for this purpose, but there are recurrent stuttering cases where 1.25 units of A is usually inserted into the thyroid muscle to see the fluency. This is done locally, but you know it's very safe, but it can be even a problem to cause you failure. So in vocal cord granulomas, these are very common during intubation, which is called intubation granulomas during traumatic intubation. And usually granulomas can be surgically removed, but people who don't want surgery can try, botulinum injections for the temporary treatment. So what will do is the granulomas will just have a, which is on the vocal cord, will have a temporary paralysis. So there won't be movement in the vocal cord. So the other will be opposing the return and cause the granuloma resolution. This is just a it and trial method, but we can try. The maximum dose is 16 units. So coming to facial palsy, which is the most common cause of idiopathic facial nerve paralysis. So there'll be one side of the face is paralysis. There'll be drooping of saliva on one side, angle of deviation mouth to the other side, and decreased frowning. So usually the standard drug of choice are steroids for facial nerve palsy. But resistant facial nerve palsy for no reason, for example, Bell's palsy has no reason for it to happen. It's 85% idiopathic, and 15 to 20% is viral and other causes. So injections can be given, in order to just improve the facial asymmetry and drinking ability. And other things are little more cumbersome, because there will be other events like more difficulty in chewing because the facial nerve innervation is more, and from one side to the other, it can result in synchiasis, which is that it can impair the other part of the face because of the innervation of the other side. And mostly the point is to reduce the involuntary movements on that side. Sometimes overdosing can cause facial nerve palsy on both the sides, but it's very rare. Facial scars, it's more used in cosmetic purposes for usually to reduce the scar size, but not completely resolve the presentation. So this acts by decreasing the tension in the wound edges, and to immobilize the facial musculature and the growth of the fibrosis. So, and it usually causes wound healing and lesser scar formation. And it's mostly given intramuscularly, just around the wound, within 72 hours of wound closure. So it's better to give before you suture the wound. And depends on the wound size, you can uh, select the dose. So dysphagia. Here, neurologic dysphagia is most commonly in CVA. So 100 units are used to inject the botulinum into the cricopharyngeal muscle, which is one of the muscles for swallowing. And it is also very, very temporary only, for namesake it's given. But there are other modes of treatment. Sorry? Hello? Yeah, okay. There are other modes of treatment also. So using a rigid scope, we can find what is the level of dysphagia at the level of pharynx, at the level of nasopharynx, or at the level of laryngopharynx. So results also are very temporary, only a year. Tinnitus is very rare. It's a ring sensation of the ear, which is happening due to multiple reasons. But this has been recommended as a first-line drug, not in tinnitus, but in palatal tumor, which is due to drug-induced or trauma or idiopathic. So in parietal tumors, we can just inject 15 units of botulinum toxin into the tensor veli palatini and the levator veli palatini. So these are the two soft palate muscles. So actually, this Penny et al. Has actually given a study of 5 patients with botulinum toxin A has given a complete resolution of symptoms within a year, and it has lasted for more than 2 to 6. So patients who are having velophalli insufficiency or a little bit of difficulty in swallowing due to palatal tumors or charge syndrome can benefit from this. Headaches are mostly uh, in botulinum. It's mostly migraine is the most common cause for the most of the headaches in the world, which is because of the vasoconstriction. So, and the dose, this is one of the terminal treatments for headaches, which is 155 units of botulinum toxin to be given. Leading to this is mostly done very rarely, but people do for resistant recalcitrant migraine attacks. So blepharospasm is inability to move the eyelid muscles. This actually works for this treatment. 80 units actually given in upper eye, and it has given you given actually good results. So it's more easily available, and injection into the orbicularis muscle is more commonly easy to find, and very minimal side effects where it's very negligible. Coming to OMD, which is the oromandibular dystonia. So this spasms mostly, dystonia means spasms of masticatory mandible and lingual and pharyngeal. So oromandibular dystonia is a very rare condition, but sometimes CVA causes all this, and we have to inject in 3 muscles, which is the submentalis, masseter, and lateral pterygoid muscles of various doses. And the most common cause of this is CVA, and complications are dysarthria and dysphagia, but it resolves mostly during a week or so. Coming to spasmodic torticollis, which is cervical dystonia, this is not a very common condition, but this is a pilot study where they've tried to inject almost 188 units in the affected cervical muscles, and there have been little bit of improvement in the symptoms, but not per se a complete treatment of choice. And it is just blocking the cervical musculature, muscle nerves, nothing else. So when dystonia occurs, the dystonia is just blocked but not resolved. So this is a basic plan of Botox, which is little very out of topic, but I want you to know this is one of the cool topics in practice for plastic surgeons and few of ENT surgeons. And it usually provides an invasive treatment from non-invasive purposes to invasive purposes, that is from facial scars to dystonia. And according to patient's choice, you can give it the treatment. And in India, the cost of each Botox comes around 25,000 to 30,000, and depends on the international units and where it's coming from. So if patient is literally affordable and the complications are explained, you can actually use in your practice, provided you have a proper backup for every treatment and every side effects. Thank you.
Thank you so much, sir. If the participants have any questions for our speaker, please feel free to drop them in the chat box. Sir, there is a request for you by the participant.
Yes.
If you can summarize the today's session.
Yeah. Okay. So basically, I just summarize it basically around 10 points. So basically, Botox is from an organism called Clostridium botulinum, which is the most common bacterium for Botox injections. The second point is it is widely used from facial scars to dysphagia to dystonia. And third of all, the maximum unit is given is around 200 international units. The lowest is around 16 units. And the basic point is botulinum toxin is costly and it can't be used for every patient in our practice. Third, the most common botulinum toxin injections used in practice now is for facial scars, vocal cord granulomas, and usually sometimes it's called as injection thyroplasty, which means that one part of the vocal cord muscle is not one vocal cord is not moving. You put those injections and you approximate the other vocal cord so that it comes close to the vocal cord and people are able to talk. I mean, talk in the sense phonate, and that is one of the greatest implications for botulinum toxin in vocal cord palsies, which is a good uh, deal for people who are aspirating and for phonation. And for facial scars, yes, it is one of the best treatment of choice for cosmetic procedures. Depending on the scar size, depending on the wound size, depending on the keloid or the hypertrophic appearance, you can give as much as possible. Once the bulge is surrounded the whole wound, you can just release the injection and may make a follow up for the second doses. And third of all, and coming to the uh, dysphagia, it's more not used in dysphagia because it's not very much common and the side effects are more. And in kids, it's mostly not used at all because it's the toxicity of the dose depends on the metabolism of the body. And so in mostly it's used in adults more than 50 kgs or less than 50 kgs. I don't recommend to do because of the metabolic activity. And you have to know that there are many types of botulinum from A to F, but most commonly used is A. And sometimes this salivary gland, salivary gland tumors, which causes excessive salivation, where people are not able to remove the gland because of inability of the surgery or not fit for surgery. You can use botulinum toxin as a drug to reduce the excessive salivation, which is one of the co- uh, best treatments for increasing the quality of life for the present patients. But mostly drug of choice is glycopyrrolate, so it's easily available. But in recurrence, it's more common to use botulinum toxin. So once you decide that botulinum toxin is one of the treatment of choice for any uh, condition, you have to prepare yourself to make the patient understand that it is one of the not the best, but an alternative treatment of choice for your present thing, because the side effects are more troublesome rather than the effects. Sometimes the side effects overcome the effects, and people, are not satisfied with the treatment of choice. So you need to choose wisely which patients, which dose, what to do, and how to do. And mostly it's a OP patient procedure, but very rarely a general anesthesia procedure if patient is not cooperative. Yeah, thank you.
Are there any further questions for Sir? Thank you so much, Dr. Jerry Ashwin, for that insightful and engaging session. Your talk has truly opened our eyes to the evolving applications of a well known drug beyond its conventional use. We deeply appreciate your time and valuable contribution to this conference. Thank you so much.
Thank you.
We are equally privileged to have Dr. V. Anand Deepak, who is a distinguished researcher recognized for his significant contributions to pharmaceutical education, clinical practice, and research advancement. He holds a Doctor of Pharmacy degree and has cultivated a professional career deeply rooted in evidence based practice, medication safety, and patient centered care. His career encompasses a blend of teaching, clinical service, and research. Dr. Deepak has been actively involved in developing and delivering clinical pharmacy curricula, supervising PharmD projects, and mentoring students in both academic and practice settings. His teaching portfolio spans pharmacotherapeutics, clinical pharmacology, hospital pharmacy, drug safety, and therapeutic guidelines development. He has undertaken multiple clinical and community-based research projects that addresses areas such as pharmacovigilance, prescription auditioning, prescription auditing, chronic disease management programs, parental nutrition calculations, herbal monograph development, and pharmacy-based health screening initiatives. His scholarly output includes numerous research publications in peer-reviewed national and international journals covering a wide range of therapeutic areas, drug safety assessments, and pharmaceutical care interventions. His vision is to bridge the gap between academic training and real world pharmacy practice, empowering future pharmacists to take proactive roles in patient care, medication safety, and healthcare system improvement. Today, he joins us not just as a scholar and mentor, but as a professional advancing the scope and impact of clinical pharmacy in India and beyond. Let's get ready to gain valuable insights from Dr. V. Anand Deepak.
Hey guys, good evening. Can you see my screen?
Yes, sir.
Okay. So let me start with my presentation today and thank you for the wonderful intro team. So yes, I'm Dr. V. Ananda Deepak and I always say my work is driven by a simple goal to make medical research meaningful for the patients. I have been coordinated phase 1 to phase 4 cardiac clinical trials, seeing firsthand like how studies move from planning to real treatment that improves patients' lives. For me, research is not just about forms or data. It's about safeguarding patients and giving them hope. And when we talk particularly about today's topic, that is the advances in cardiovascular therapeutic interventions through the lens